Okay.
I'm going to ask some questions, so maybe unmute yourself when I ask the questions. I'll just, if no one kind of yells out, I'll maybe just pick some people. They're not at all hard. So, okay, so I'm going to talk about diabetic macular edema. I'm Ashley Crane. Let's see. Okay, so this is chapter 5 in your BCSC, talking about retinal vascular disease, and they have a very small section about diabetic retinopathy and diabetic macular edema. So we're just going to go through what your book basically for OCAP's review talks about. And so since it's such a small section, really this is basically everything they have in the section about diabetic macular edema. So it results from a hyperglycemia-induced breakdown of the blood-retinal barrier, leading to fluid extravasation from retinal vessels into the surrounding neural retina. And it can be associated with hard exudates. Can anybody tell me what hard exudates, it just seemed like a good exam question. What makes up hard exudates? A guess? Any guesses?
Lipid?
Yeah. There's also precipitates of plasma lipoproteins. Okay, an FA. What is the role of FA in diagnosing diabetic macular edema? We know some of the roles in maybe proliferative or non-proliferative diabetic retinopathy, but it's not something we use too often to diagnose diabetic macular edema. But it may show the breakdown of blood retinal barrier by showing retinal capillary leakage, but it's not the appropriate test to evaluate for the presence or absence of edema. So you can't use this instead of an OCT. Why might that be? Maybe Philip? Or really anybody? Why might that be? Why might it not be the best test?
I would assume OCT is more sensitive for the macular edema.
That's true in some ways, but maybe the opposite could be true too, because you can see leakage, small vessel leakage in the macula on FA on lots of diabetics, but they might not actually show leakage on the OCT. There might not be fluid on the OCT because our RPE can pump out fluid, and so it really depends on the leakage versus the pumping out. So if we're able to, if our retinas are able to keep up with it, then you might show leakage on an FA and not on an OCT.
So Guy, I can tell you as someone who's old and started prior to OCT, I was shocked when we got the OCT machines in my diabetic patients, where a lot of them looked like they had clinically significant macular edema and the OCT showed them to be dry. It was very striking.
Right. And that's true on in a lot of retinal diseases. You can have leakage on the FA and not actually show fluid on the OCT or edema on the OCT. Okay, so there are classifications of macular edema in BCSC. It's center involved or non-center involved, and it's based on if the central retinal subfield shows thickened, appears thickened on the OCT. So the ETDRS was, there are a lot of studies that are basically touched on briefly in the textbook. So we're just going to go through not through the whole study, but what the key points on the BCSC they hit on. So the ETDRS was the first randomized clinical trial of photocoagulation in diabetic patients with less than high-risk PDR, and it defined CSME as the indication for focal laser. Now, this is really important. I mean, it's not something we use a lot these days because it's by the slit lamp, not by the OCT. But please, somebody tell me any of the three answers of what is CSME?
Retinal thickening near the macula.
You go ahead, Sahas.
Jacob, we can tag team it.
Yeah, okay, what you got?
I got retinal thickening. I think it's 500 near the macula. 500
Yeah.
microns.
And then the same for hard exudates.
Okay, associated with thickening. Okay. And there's one more.
And I think it's like maybe 1,000 microns out, or like there's edema associated with exudates. It's like 1,000 outside.
Okay, so everybody just look at these diagrams. This is something you absolutely have to know for your OCAPs and for your boards, regardless of whether it's clinically that helpful. There are three definitions: retinal thickening located at or within 500 microns of the center of the macula. Number two, hard exudates at or within 500 microns of the center of the macula if associated with thickening of the adjacent retina, or a zone of thickening larger than one disc area if located within one disc diameter of the center of the macula. So you just have to know those. You have to have those three things memorized. Okay. So the book also goes into focal and diffuse macular edema, which is also something not used so often, I guess, in clinical practice. We don't think about it quite that much, but I mean, it does make sense. There's focal macular edema is characterized by areas of focal fluorescein leakage, macular lesions. Sorry, that's not my phone. Okay, such as microaneurysms. Diffuse macular edema is characterized by extensive retinal capillary leakage and widespread breakdown of the blood-retinal barrier, often accumulating in a cystoid configuration in the perifoveal macula. And studies don't really show any difference in the treatment response between the two of those types of macular edema. So another question coming up: treatment of diabetic macular edema. So treatment is typically indicated when macular edema is center involving and affects visual acuity. And that's kind of treatment in a lot of disease states, but treatment for diabetic macular edema and, for instance, treatment for central retinal vein occlusions is different than treatment caused. We should look at those as those treatments for those two disease states differently than we look at treatment for, say, AMD, something caused by a CNVM, which you have to be potentially more aggressive about. But let's talk about treatment of diabetic macular edema. What other factors may be at play that would lead you to not have to treat diabetic macular edema when it looks like their vision is down? What are the other comorbidities you have to look for in diabetics in particular?
Hypertension.
Yeah, that's true. I was more thinking, what are other ocular comorbidities might drop their vision that you have to parse out whether or not the vision loss is due to diabetes or diabetic macular edema, or due to something else that's not going to be treated with, say, an anti-VEGF.
Changes in the lens.
Yes, cataract, yes. So just some examples. Certainly refractive error, cataracts, macular ischemia. You can have a lot of patients who've been diabetic for a long time. They have kind of an ischemic retina with some thinning and loss of inner layers, and they might also have macular edema, but their vision might not improve if you get rid of the macular edema, if that's not the culprit. Pre-retinal traction like epiretinal membranes, if the patient has PDR and they have pre-retinal tractional membranes, that might cause the macula to look edematous when it's more traction. You also have to think about whether or not the DME is going to get worse. So planned cataract surgery and planned PRP are good reasons to potentially treat diabetic macular edema when you might otherwise not want to treat it, because they definitely do get worse in some patients. And so it's I find it's nice if there's some DME to give treatment for for the DME before a PRP, because I don't want to discourage the patient from coming back when their vision drops a line or two after the PRP. I don't want them to think that that's going to continue. So
And
also,
Dr. Gray,
yes.
um, for patients who are possibly going to undergo cataract surgery or PRP, do you treat until there's no edema, or do you treat till there's like stability in it prior to them, like you saying, okay, now's a good time for cataract surgery or PRP?
I think if somebody has, I don't necessarily delay their cataract surgery or their PRP, but I certainly would give at least one shot if I think that they have borderline visually significant edema. And I think if you have a compliant patient that you think is definitely going to come back, giving a couple shots before a PRP is not the end of the world. But you have to know your patient population. And if you think that they might not come back, the PRP is, if they have PDR, is by far the most important. So you have to get that done. But it's nice, like in cataract surgery or PRP, to kind of get ahead of the edema by treating it at least once in advance, so that it doesn't get so much worse that the patient is very, upset about having had the PRP. They think that that the PRP is detrimental to their vision. So I think it keeps patients coming back when they see better. So also, you have to think about if the DME is going to get worse, because what their A1C is. It's hard to get an A1C on a lot of patients. They don't know the number, but I encourage you to try to get it. If you can, call their PCP or order it just to find out. It will help guide you. So treatment of DME obviously can include diabetes control, getting the A1C down, focal laser photocoagulation, and intravitreal injections are really the mainstays of our treatment now. So anti-VEGF. So the last version of our book is what we're going to go by, and they include these 4 agents listed per the BCSC 2020 to 2021, which one of them we don't use really anymore, but the other 3 we do. The DRCR NET Protocol I was the first phase 3 trial to demonstrate that intravitreal anti-VEGF provides superior visual acuity outcomes as compared to focal laser for center-involved DME. So that's important to know. And let's look at some of the DRCR NET protocols. So this is protocol I, and we can see that it's comparing ranibizumab with prompt or deferred laser to triamcinolone with laser or sham with laser. And so as you can see at the top, we're looking at the change in visual acuity on the vertical axis, and on the horizontal axis, we're looking at the week's visits. And ranibizumab with prompt or deferred laser. And deferred laser was defined at greater than or equal to 24 weeks. Was significantly superior at the 1 and 2 year follow-up in increasing the visual acuity than the laser treatment alone or the triamcinolone plus laser for center-involved DME. And after 1 year, the eyes in the ranibizumab groups gained an average of 8 to 9 letters, which you can see there on the vertical axis, versus those with the laser monotherapy group, which are more around 3. And as is the Triessence arm. So through 5 years of follow-up, despite the number of injections going down, the ranibizumab, the anti-VEGF patients still do better. And adding focal or grid laser at the initiation of the injection is no better and possibly worse for visual outcomes than deferring the laser for 24 weeks or more. So really just treating these patients with anti-VEGF, they're doing better. The rise and ride studies, these can and will be tested. So remember them. They're both, basically they're identical studies. And at 36 months, the pooled data, these studies, which I'm going to show you in a graph in a second, shows that the proportion of patients who gained 15 or more letters, which is quite a few letters, of visual acuity from baseline in both of the 0.3 and 0.5 groups were 41 and 44% respectively. So quite a lot of people, almost half the people gained 15 or more letters. So you can see that here. And we're going, weeks down, or excuse me, months down here. So here we're at 2 years. I don't know if you can see my cursor, maybe you can't, but at 24 months, we're looking at that improvement. And the top two lines are the pooled rise and ride study. So let's see, and then versus the sham study at the bottom.
Does that also show that earlier initiation kind of will lead to quicker results? Because if you look at the crossover portion, they don't actually.
They don't. Yes, that does. There is at the crossover. They don't reach the top. So they don't reach where ranibizumab was. So yeah. So the VIVID and VISTA studies looked at aflibercept, and after an initial phase of 5 monthly injections, after 148 weeks, the groups undergoing therapy with aflibercept, both monthly and every 2 months, had a much better visual gains compared to laser. And we can. I don't think I have a graph for that one. So the VIVID and VISTA really also helped to get FDA approval for aflibercept. And then we can go on to Protocol T, which really looked at our 3 main anti-VEGFs, aflibercept, bevacizumab, and ranibizumab for the treatment of DME. And it showed superiority for aflibercept over bevacizumab in improving ETDRS visual gains at both 1 and 2 years of treatment. And it's also superior to ranibizumab at 1 year, but very, basically they converge at 2 years. And as you might imagine, the differences between the agents are primarily seen in the effects in eyes that have worse baseline vision. So perhaps it makes more sense for you to treat with some of the more expensive agents in patients who have poor vision to start with, and maybe you can start with the Avastin in patients who have better vision to start with, because they won't gain as much if you're having to choose like that. Protocol T, this is important because it's something that you may need to counsel your patients about, because a lot of the diabetic patients are patients who have a lot of other comorbidities. So the combined rates of non-fatal MI, stroke, and cardiovascular death were higher in Protocol T, with specifically in the ranibizumab group, than patients treated with the other 2 agents. But extensive analyses of adverse events on other studies have not shown a consistent difference between those 3 agents in terms of systemic safety. So you might need to counsel your patients if they've had a recent MI or stroke, that this was seen in one study. So here we go through a little cartoon of Protocol B, and it basically shows laser versus steroid injection, and looks at the visual acuity over the months. And we can see that in this study, focal or grid laser was more effective in improving the mean visual acuity letter score than was either 1 or 4 And then they also talked in the book about protocol I, which is ranibizumab plus or minus laser. And it shows here, if you look at the top versus the bottom again, that ranibizumab plus or minus laser is greater than laser alone, which we kind of saw already in another cartoon. So can you, the residents tell me, do you use a lot of corticosteroids in diabetic macular edema in your clinics?
If they're refractory to the other anti-VEGFs, we sometimes will do it.
You do. Which agent do you go to first?
I think triessence.
So you do intravitreal triessence?
I believe so.
And do you use,
That's what I've seen as well.
I've seen the Ozurdex implant.
okay, is that mostly at your VA clinics, or is that mostly your other private clinics? Or
The Ozurdex was at the VA.
Yeah, I've seen Ozurdex at VA, and then I've seen triessence used at USF.
yeah, I think that makes sense. It's a lot due to the payer mix, and the VA you'll have more the more expensive medications may be more available to you. So I do encourage everyone to, if you're going to be doing injections, especially after your residency, to really take that VA experience and try to see how those patients do when you have all of your options. Because that's something that, for instance, in my residency, I was mostly working with uninsured patients. It was very hard to get them Ozurdex and some of the more expensive medications, and so for that reason, I had less experience with them. So just try to pay attention, when you do have that option. When we were looking at the DRCR, we were looking at all eyes in terms of triessence versus laser, or we were looking at all eyes in those charts. But if you look at just pseudophakic eyes, the triessence did similarly to ranibizumab and better than laser. So just to remember that, you have to really self-select either a patient who's already planning to do cataract surgery, or a patient who's already pseudophakic for these patients, to give them corticosteroids. So you have to remember the risk of increase in IOP, cataracts, retinal detachment, endophthalmitis, vitreous hemorrhage, and floaters is maybe, depending on the agent you use, similar risk to intravitreal anti-VEGF. So here we get to the surgical management of DME. This is something that, do you do this in any of your clinics? Do you use focal and grid laser anymore? Or maybe you're using micropulse or something else?
I haven't seen it done.
Okay.
I haven't seen any focal laser.
We've done a few focal lasers.
What did you say? What was that last one?
We've done just a couple focal lasers for
Okay.
aneurysm
Jason talking?
outside of outside of the fovea.
Okay. Yeah, I think that was my experience in residency as well. I think it's certainly focal and grid laser has fallen a bit out of favor in favor of anti-VEGF, but it can be used as an adjunct in eyes resistant to anti-VEGF for focal leakage away from the fovea, and it's also helpful in patients who are just not going to come back. Maybe you can think about it, I think that's probably a lot of our diabetic patients are not necessarily going to be coming back. Jason, I think I can still hear your typing. Thanks. So the ETDRS basically showed a decrease in moderate visual loss, an increase in moderate visual gain, decrease in thickening in focal laser for CSME. Eyes with less than CSME showed no benefit of treatment for 2 years. So that's important because, in the beginning, we didn't know the answer. Should we treat diabetic macular edema if it's less than CSME? Will that help the patient over time to maybe? So adverse events may include paracentral scotomas, transient increases in edema or decreases in vision. I think that's really important for us to know because we want patients, it's the same in PRP, and we want the patients to really come back. Laser scar expansion, of course, you know, when you put in any laser spot, it you know, a few weeks later, it's going to be large. Sorry, my Zoom just turned off and on. Can everyone see me still?
See you.
Yes,
Yeah,
yes.
we lost the screen.
Lost the screen. Okay,
Yeah.
hold on. Okay, can you see my screen again?
Yep.
And inadvertent foveal burns really would be, I've seen one patient that came into our emergency room in residency who went from 20/25 to hand motion after a focal inadvertent foveal burn. So certainly there are risks.
And Dr. Crane, I haven't seen a study like this, but do you know any studies that have looked at the spacing of laser and kind of compared the different spacing and seen, you know, what's the, like, how far can they actually space out the burn spots that can still be effective?
Yeah, we do have a guide for the focal and grid laser parameters actually from your book. So yes, there are guides for that. First, you use the FA as a guide, especially if you're trying to hit particular MAs. You know, some people say that that's not helpful to use the FA as a guide, but when I've done it, I certainly think that it's helpful. The size should be starting between 50 and 100 micrometers, and I would start more towards 50. The duration should be 0.1 seconds or less. And you can use yellow-green or yellow-green wavelength. And for focal leakage, it's really between 500 and 3,000 micrometers from the fovea. And for diffuse leakage, you would use a light intensity grid pattern. And it can be repeated as often as every 4 months. And like I said, micropulse laser may be an adjunct, though I haven't had much experience with micropulse laser because we really didn't get it in my training facility until the very end of when I left. And all right, so yellow-green wavelength, everybody, is what it's in your book. Although you might not have that particular laser, and you can use your standard laser, and it can be repeated as often as every 4 months. So in terms of the surgical management for DME, what I was saying, I don't know if I was lost before that, is that really the first bullet, in my opinion, is the most important, that if the patient has DME, or you think they have DME, but they also have you know, an epiretinal membrane or some kind of posterior hyaloid traction, this may be a multifactorial edema situation. And so a vitrectomy with a membrane peel may help relieve at least the posterior traction, and then perhaps the edema can be treated better with anti-VEGF. We do know that vitrectomy generally improves the thickening in eyes with DME, but a lot of studies have shown inconsistent effects on improving the visual acuity. So it's not a reliable use of vitrectomy to treat DME. So in protocol D, which was an observational case series, it showed that after vitrectomy, you know, retinal thickening was reduced, but the vision remained pretty much unchanged. So there's been several studies that have shown that. I have several cases that are not to do with the lecture, but several DME cases, and maybe I'll just show one case. And so this is not my own case, but a case from training. And that this is a 60-year-old man diabetic on for 15 years on an insulin pump, known DME, has had at that time a lot of injections of both Avastin and Eylea, and the vision was just 20/40 in the affected eye. And you can see here the FA and the OCT. The FA was actually done in particular to look for NVE, but it does show there's some leakage. It's not the best photo, but there's some leakage there. So this patient underwent an argon laser, focal laser to that circled area, 50 microns, duration 100 milliseconds, energy 140 milliwatts, and 47 shots. And you can see on the left, 3 months, before focal laser on the left, 2050, 2040, and 3 months after the edema is improved. It's now outside of the central subfield, and the vision has improved. So certainly, and then vision 3 years after focal laser, he never had another injection, and his glucose had improved on the pump. So this is not, just to say, I know that in training these days, we don't do focal laser that much, but it can be really helpful. That's the difference between this gentleman needing 3 years of laser and nothing at all after focal. So just remember it. And I think I'll go to the very end because I had a couple more cases, but I'll let everybody else give cases.
Dr. Crane, may I ask a quick question here?
Sure, of course.
For just looking at that patient's swelling in the eye, like I also think like retinal detachments where like if you've got enough fluid there, laser won't actually take for barricading. And I know it's different anatomy that's being elevated here, but is there a thickness that laser does not take well and would preclude you from doing any sort of laser?
Yes, if the retina is detached, then your laser won't take up. But I have not done laser on any macular edema that you've not been able to take up. Certainly, you might be getting to powers. Whenever you get to a high power in general, it does make you nervous. You're trying to do this in a very low power situation. But I don't think that's going to be a problem for you in focal laser. Does anyone else think that that's a problem?
This is something we used to talk about all the time before anti-VEGFs. And one way to focal laser, which is challenging, but it is Scott and Dr. Pavin, or Scott and Reed, I guess, Dr. Potler and Dr. Pavin are here, they'll probably chime in too, is that really you can focal laser the microaneurysms. And in that situation, a swollen retina is maybe a little bit better because it protects the underlying, the RPE. And the yellow-green, we have a yellow laser in Clearwater. There's not a lot of yellow. Yellow is good for that, but the new frequency doubled solid state lasers are yellow-green. And with a 50 micron spot 50 micron spot, maybe 100 milliwatts and maybe, 1 second, maybe not 1 second, maybe 0.1 seconds or 0.05 seconds, you can get takes on the microaneurysms. In those cases, you don't get any RPE scarring. It's a very safe laser. It's not easy. You have to be perfectly still, and the patient has to be perfectly still. But there is a way to focal laser microaneurysms, and those patients do great. And often the aneurysms that need the lasering are the fattest. So anyway, you guys think the same? Or?
So that's exactly how I typically will laser. I generally will laser the microaneurysms. These days, I only really laser patients who have focal edema, outside center of the macula. If they don't have any center involved edema and they have, a nice area of focal edema outside the center, then I will do that. And I laser the microaneurysms also in patients who I have on anti-VEGF therapy and they're just not drying up. You'll find that sometimes those areas of focal edema are not real amenable to anti-VEGF therapy for some reason. So, adding a little focal laser to those patients may help you extend their treatment intervals a little bit. And I rarely do grid laser. I typically will laser the microaneurysms.